Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, CardioNerds. This is Dan Ambinder here, and we are so excited to rejoin for another wonderful CardioNerds Beyond the Board series episode where we build on the Mayo Clinic Cardiology Board Review course to go beyond the boards to put our knowledge to practice with a series of illustrative cases. Today, we're going to be diving into primary prevention, a very, very important subject that's near and dear to all of our hearts. So joining us are our lead fellows, Dr. Jaya Kanduri and Dr. Jason Feinman. Jaya is an interventional cardiology fellow at Cornell, where she also did her chief year and general cardiology fellowship. Her interests lie in microvascular dysfunction, shock, and medical education. Glad to have you back, Jaya. Welcome, welcome, welcome.
Thanks so much, Dan, and happy to be back with our star team. Our other cardio nerd, Jason Feinman, is a current chief cardiology fellow and future heart failure fellow at Mount Sinai Hospital. His passions include cardiogenic shock, hemodynamic support, and clinical research.
Thanks, Jaya. And we're pleased to introduce Dr. Stephen Kopecky, who is a master clinician and educator at the Mayo Clinic, where he serves as the director of the Statin Intolerance Clinic. He's a highly acclaimed national and international speaker on cardiovascular disease prevention. Welcome to CardioNerds, Dr. Kopecky.
Thank you. Thanks for having me.
Dr. Kopecky, we are truly so excited to have you on the show, and we're so excited to learn from you. Before we get started, though, I do have a question. What is one myth about statins that you feel most passionate about debunking on the air?
Well, that's a great question. And one myth I deal with every day is that statins and lipid-lowering therapy is not beneficial, in that you go on the internet, a recent study of 60,000 mentions on the internet, 98% of them were not positive. And so there's a lot of myths out there that we need to bust and help people understand that cholesterol is a problem and that we do have effective medications to lower it.
I love it. And hopefully we can make that point today. So on that note, let's get into our cases from the CardioNerds Primary Prevention Clinic. We'll start with Mrs. Simi Statinia, who is a 45-year-old South Asian female with a history of preeclampsia and GERD, who is presenting for a primary care clinic visit. She reports trying to remain active with walking and jogging a few times a week and has no symptoms to report. She is a never smoker. Her blood pressure in the office is 130/80, and she had a routine lipid panel checked with a total cholesterol level of 260, an LDL of 160, HDL of 45, and a triglyceride level of 210. She is wondering if she needs to worry about having a heart attack in her future. Dr. Kopecky, how would we interpret this patient's risk for future cardiovascular disease events? Does she qualify for our pooled cohort equation for 10-year ASCVD risk?
Well, it's a very good patient to start with, in that it's a very common scenario that we see. This is a relatively young woman, and women, especially young women, are always pretty much low risk when you look at them with the pooled cohort equation. Now, the pooled cohort equation is what we've been using the last few years. It is based on a cardiovascular risk factors. We all have it on our phone or on our desktop, and it will help give you a percentage risk for a fatal or non-fatal MI or stroke at 10 years. It also gives a lifetime risk. So in these younger women, I tend to not only look at the 10-year risk, but also the 30-year or lifetime risk, because that's usually higher in them, and it tells them the true story over what they're dealing with over the next few years.
That's very helpful. I guess, how do you, Dr. Kopecky, take into account other sorts of risk enhancers that may not necessarily be available to us on the calculator?
Yeah, that's a good point too, in that the 2018 guidelines, American College, American Heart, tried to say a single equation doesn't fit everyone. And so the pool cohort doesn't fit everyone. There's a lot of nuances and things that we don't really know about. We know they're risk enhancers or risk increasers. And so here's a list, and they put a list there for us. And to look at this list, it really is things that will increase inflammation. Inflammation, we know, plays such a big role in coronary artery disease and atherosclerotic disease. And they really fall into three categories. They're the history of the patient and their comorbidities. Next is the lipids and the biomarkers. And then the third, there are some things we should do in individual patients as the need arises. So the history is like a family history of early ASCVD, less than 55 in a man, 65 in a woman. or ethnicity. We know that South Asians certainly have increased risk, like this patient that you just presented. Even with the same risk factors, they have a higher ASCVD risk. Patients with chronic kidney disease, that's a classic cause of chronic inflammation. Patients with metabolic syndrome, the big abdominal visceral adiposity is certainly pro-inflammatory. And I'm glad to see we're starting to have in the guidelines conditions specific to women, pregnancy conditions, preeclampsia, gestational diabetes, premature menopause, all very important. And then finally, inflammatory diseases like rheumatoid arthritis, psoriasis, HIV, and even just regular degenerative joint disease can increase your cardiovascular risk. Now, the second group, the lipid biomarkers and LDL over about 160, and then persistently elevated triglycerides at 175. And she would really fit both of these categories, the patient you presented. And then finally, in some patients, you can do a HSCRP if it's elevated over 2. That increases risk. If they have peripheral disease and ankle brachial index less than 0.9, that would certainly increase risk. And these are things we all factor in. And the final thing is lipoprotein A. And that has gotten so important because as we get these drugs that are coming in the next few years, it'll be good to tell patients that you're at increased risk, but we have something coming to help.
Wow, that was an excellent summary of other things that we should be looking for in our patient's history. And as you mentioned, Dr. Kopecky, this patient did have a couple of hidden things that we may not always be clued into, such as her history of preeclampsia and her ancestry from South Asia. I guess another thing I wanted to mention is checking things like high sensitivity CRP, Lp(a), and the other one to mention is ApoB. And I was wondering when you think it is appropriate to be checking these tests in addition to our traditional lipid panels.
Yes, good point. The lipoprotein A, the guidelines actually suggest that we check it when there is a family history of premature ASCVD. So again, younger men less than 55, women less than 65, because about 20% of the population has an elevated lipoprotein A. And the guidelines in the U.S. have defined it in nanomoles per liter as normal up to 75, and certainly risk starts to increase over about 125. The other time to check something different would be when to check an ApoB. Now, apolipoprotein B is really important because it's the receptor site on the LDL that really causes a lot of the download of lipids, and it causes atherosclerotic plaque. And the guidelines there have called for checking an ApoB if the triglycerides are over 200. To calculate LDL isn't as accurate then. And they say just if you have trouble, because now the guidelines are also saying you don't need to do a fasting lipid panel. If they're not fasting, the triglycerides are high, just do an ApoB. And if it's greater than 130, that certainly is increased risk.
Thank you so much, Dr. Kopecky. That was incredibly helpful. Moving back to our patient, Mrs. Statinia, if we are to plug in her demographics into the traditional ASCVD score, it's actually quite low. It's around 2%. But given our concern for her risk enhancers, she is wondering if there's potentially a test she can get to clarify her risk further and potentially help with the decision of starting a medication like a statin. At this point, given the information that we have, what would you recommend, Dr. Kopecky, as a potential next step or a test that may be helpful?
Well, you pointed out that she's active, she jogs, she does well there. So a stress test really is not going to help us. It tells us what the patient tells us, and she'll do well on that. We can consider things like imaging, maybe a carotid ultrasound to see if she has atherosclerotic plaque in her carotids. The other thing to consider is maybe a coronary artery calcium score. You just have to be a little careful with the calcium scores in young women because they may be negative. If they're positive, it really tells you something significant. The other thing is that calcium scores, I usually try to talk to patients beforehand and say, if this is abnormal, talk about recommendations to make this improve or lower your risk. Because the other side of the coin is if it is negative, if a calcium score is negative, sometimes patients think, oh, I've got a get out of jail free card and I don't need to do anything. I point out to them, no, if it's negative, I'd still like you to change your lifestyle, eat differently, be more active physically, take care of your stress and your sleep. So as long as you talk about that up front, the calcium score can be quite helpful.
So to your point, Dr. Kopecky, Mrs. Statinia does get a coronary calcium score, and it comes out to be 120. She's wondering what the next step should be based on this result, and if she needs to start a medication. What calcium scores warrant lipid-lowering therapy, and to what LDL goal should we be aiming for in a patient like this who is asymptomatic?
Yes, so she is a primary prevention. She doesn't have any disease that we know of. The FDA does not call coronary calcium having ASCVD, and so most drug companies and guidelines don't either. However, the 2022 guidelines did come out and tried to codify for us what calcium score do you act upon and how aggressively do you act. And it was a very nice graph that they put out that says if your calcium score is 0, then you really don't need to do anything for the patient other than lifestyle. You don't need to start a statin unless they're a smoker, unless they're a diabetic. Those are intrinsically higher risk. And they also point out you shouldn't be doing calcium scores in people that have familial hypercholesterolemia, because some of these younger patients may have lipid-rich plaque without calcium, and you may get a score of 0 that is falsely reassuring. Then if your calcium score is in the 1 to 99 range, that would favor trying to treat the patient, especially if they have other risk factors like elderly over age 55. Then the goal LDL is less than 100. And then as the calcium scores goes up over 100 or 75th percentile, it suggested you start statin therapy with a goal LDL less than 70 milligrams per deciliter. And it also suggests adding ezetimibe to those patients to help get to goal if you need to. And then the final group is the calcium score over 1,000. And these are incredibly unusual patients, but when they have it, you really have to be concerned about their risk. And there, the goal, again, is less than 70, but now it's not only is suggested to add ezetimibe to the statin, but also a PCSK9 inhibitor if needed.
That was really, really excellent. Thank you, Dr. Kopecky. On that note, do we have any sort of algorithm for how we incorporate aspirin in primary prevention?
Well, yes. And aspirin has taken a hit in the last few years with some of the studies that have come out. The New England Journal had 3 or 4 of them in a row there. And what the guidelines recently pointed out in the primary prevention guidelines was, first off, don't give aspirin routinely for patients over 70. And we used to be our standard. And don't do that routinely, only if they have increased risk, because the risk is greater than the benefit. The second group that they comment on is, again, it's a class 3 recommendation. Don't give aspirin for primary prevention for ASCVD in adults of any age who are at increased risk of bleeding. And the reason for that is because the benefit from aspirin isn't as great as we once thought it was. So if patients have increased bleeding risk, don't give it to them, really, no matter what their risk is. And if you do want to give it because of high risk, then you certainly need to have a conversation with them. And finally, it's a 2B recommendation to consider aspirin for primary prevention in adults age 40 to 70, which would certainly fit this patient, who are at higher ASCVD risk, but not at increased bleeding risk. So this very nice patient that you presented may fall into that group. She does have other risk factors. And the last thing to consider is lipoprotein A. Any patient with elevated lipoprotein A, there's not been randomized trials, but there's been a lot of database analysis that shows that patients with high LPA, they benefit from aspirin, probably from inhibiting not so much inflammation, but maybe some of the clotting mechanisms. So those are ones to certainly consider, because it does seem to lower their risk if they have a high LPA to start.
Wow, that's super helpful. I think I'm going to be checking LP(a) a little more frequently in practice based on what you just said, Dr. Kopecky. That was great. So I guess with our patient, we will have the potential for starting aspirin as well as a statin. And other things that you generally think of when we are evaluating patients for hyperlipidemia, such as secondary causes, what goes into their diet, and other sorts of lifestyle factors. How do you generally counsel these types of patients, Dr. Kopecky?
Yeah, one easy way I remember it, or try to remember it, is think about secondary causes that are in the realm of diet, as you said, in the realm of drugs, in the realm of other diseases, and then disorders of metabolism. And the diet, we actually published a paper recently on patients on keto diet and how they presented to our familial hypercholesterolemia clinic because their LDL was greater than 190. And it was all because they were hyperabsorbers on a high saturated fat keto diet. Paradoxically, also, anorexia can cause a very high LDL cholesterol. The drugs, there are a couple of drugs to be always aware of that we use a lot in cardiology, of course, which is diuretics and amiodarone. They can actually raise cholesterol. Not as much. It's a bell-shaped curve, and some patients get a significant rise. There are patients that respond to retinoic acid, which is a very commonly used drug now, and that can raise your LDL, as can some of the immunosuppressants like cyclosporin. But the two things I really encourage fellows and staff and anybody that treats these patients not to miss are two very important diseases. One is biliary obstruction. The classic model is like primary biliary cirrhosis, where you have cholestasis, which will markedly raise your LDL cholesterol, and it can do it very rapidly. And the second disease is a nephrotic syndrome. And proteinuria, a lot of protein can actually increase your LDL significantly. So take a look for some of those diseases, do some liver function testing, do some protein analysis in urine and serum, and make sure they don't have that. And then finally, there are a couple of metabolic problems. One is severe obesity can be associated with high LDL, a low T4. Again, these usually aren't that drastic on how much they'll raise it, but it is a bell-shaped curve. And then sometimes pregnancy can do it. And the issue with pregnancy I bring up because we don't want to give statins during pregnancy. And in fact, as an aside, I tell patients, don't take your statin. Start the day that you're considering getting pregnant, and you could restart the statin the day after you stop breastfeeding. So those are four groups really to think of and look at.
Fantastic. Okay, so let's move on to our next case. So we have Mr. Ross Bastat, who's a 68-year-old gentleman, the history of hypertension, diabetes, and coronary artery disease, who's had a myocardial infarction and has had a PCI to his proximal LAD 6 months ago, and he's presenting to your office for a follow-up visit. His lipid panel was recently checked and showed an LDL of 70 on rosuvastatin 10 daily. He's also taking aspirin 81 milligrams daily, as well as ticagrelor 90 milligrams twice a day. Based upon his lipid panel and his history, do you think that there's room to optimize this patient's cholesterol further?
Well, there certainly appears to be. And one of the issues is that we've had studies now in the last couple of years that have kind of guided us on our LDL goals. And one was the Get With the Guidelines program that showed that the average LDL cholesterol at the time of first heart attack or first stroke is 105 milligrams per deciliter, which is a lot lower than people would think. And so from that, the idea has come in the guidelines that for primary prevention, try to get LDL less than 100. Now, a second series of studies primarily have been done with some of these very good lipid-lowering drugs like the PCSK9 inhibitors. Very elegant studies with intracoronary ultrasound showed that once you get an LDL below about 55, you can actually have regression of coronary artery disease that is lipid-rich. The calcified fibrotic plaque will not resorb, but the lipid-rich plaque can. And so that's why the goal now is in guidelines, if you have secondary disease, like this patient does with prior bypass and prior stenting, then try to get the LDL cholesterol less than 55. And he's on rosuvastatin and has an LDL of 70, so he would certainly fit in that category.
That's fantastic. Can you talk a little bit about how much we'd expect his LDL to improve with increases in his rosuvastatin dosing?
Sure. And that's an excellent point to bring up in that when you double a statin dose, no matter what the dose is, you'll get another 6% reduction in your LDL cholesterol. And so if you go from 10 of rosuvastatin to 20 or from 20 to 40, you only get another 6% reduction in general. And you expose patients to higher risk of side effects too from the statins like myalgia. So what has been done is looking at another generic drug, ezetimibe, which is a Niemann-1, PIK1-like receptor inhibitor in the small intestine, so we don't absorb as much cholesterol in our gut, in our small intestine. And the racing trial actually looked at that and looked at doubling the statin dose versus keeping the statin dose at the same, like 10 milligrams of rosuvastatin, and adding ezetimibe 10 milligrams daily. And while the doubling the statin dose gave them about a 6% reduction, adding the ezetimibe instead will triple that. They'll give you about a 20% reduction, and it does lower cardiovascular events, and it had less side effects. So I think now that ezetimibe is generic, we're starting to use that more and more, and it's starting to creep into the guidelines too, which I think is very helpful. So think of now hyperlipidemia as almost like a hypertension. We approach hypertension, we change lifestyle, we add a little diuretic, we add maybe a calcium blocker or an ACE or an ARB, give lower doses so you achieve better effect without side effects. We're getting to the same point now, I think, with lipid-lowering therapy. Work on lifestyle, give a little bit of a statin, then think of adding in ezetimibe, two different mechanisms to achieve a benefit with less side effects.
I think that's fantastic. And I think just on the topic of all these things, to make it clear for all of our listeners, do you mind just detailing who you use a goal of 100 for, who you use a goal of 70, and who you use a goal of 55 for?
Yeah, that gets confusing, all these numbers sometimes. And so when you think of risk stratifying patients, we ask three questions. Basically, is ASCVD present? And yes or no. If it is present, then they should have an LDL. All those should be an LDL less than 55 because they have coronary artery disease. They have coronary artery plaque. There may be a few patients, maybe 10%, that are very stable. They had an MI or a stent 10 years ago. They've been rock stable since. They have minimal other risk factors. They could be a 70, but that's the rare patient. The next question you ask is LDL over 190? If it is, then they could be an FH type of patient. And those are the ones we tend to try to get their LDL lower, especially if they have something like lipoprotein A elevation, which is very common in patients with FH. It's 20% in the general population, but it's about 50 or 60% in the FH patients. And those are the ones we try to get, probably down to 55 if they have other risk factors, other risk enhancers. And like we talked earlier, if they don't, then probably at least an LDL of less than 70. And then the next group is the diabetics. If they're diabetics, yes or no. And if they are, we do a risk calculator for them, do the pool cohort. Those first two groups, we do not do the risk calculator on because they're already assumed to be high risk. And the diabetics, we could look at their risk. If it's over 20%, we would try to get a higher dose statin, get the LDL less than 70. And if they're not, then look at the diabetic risk enhancers. And these are specific for diabetics. And think end organ damage in this case. And so when I say end organ damage, it could be things like retinopathy, neuropathy, nephropathy, GFR less than 60, or they start to have urinary albumin that's increased over 30 per milligram of creatinine, or they have peripheral vascular disease. That's a very high risk, probably the highest of all the vascular beds. If they have an ABI less than 0.9, then think of being more aggressive and getting that LDL down to 70. And if not, then maybe an LDL of about 100. And that leaves us with the largest group, which is really the group that we talked somewhat about earlier that have the risk enhancers, the ones that have no disease, no diabetes, and LDL less than 190. Then those are patients that we in general try to risk stratify with the pool cohort, look at the risk enhancers we talked about earlier, some of the historical factors, their comorbidities, their family history, the other markers. And if they have a significant number of comorbidities, risk enhancers, then try to get their LDL down, certainly less than 70. The LPA is significantly higher, maybe less than 55, but in general, they're a 70 or 100 for these primary prevention patients.
Thanks. I think that's incredibly helpful. I'd like to bring it back to our patient. So we speak with Mr. Vastatin. He agrees to increase the dose of his rosuvastatin to 20 milligrams a day. And his goal, like you had said, of getting his LDL closer to less than 55. Unfortunately, he comes back to clinic a few weeks later and he's complaining of lower extremity muscle pains and he really wants to stop the medication. How do you handle these patient scenarios?
Boy, we see a lot of these patients. And the first thing with statin intolerance, myalgias are 90% of the intolerance, and diabetes can be an issue, but it's mainly these myalgia patients. And you just have to believe them. You have to say, I understand, I agree with you, you have pain. One problem is you get past age 60, everybody has some pain. So I talk to them about it. Is this a severe pain? Can you live with it? If it's not bad, maybe just put up with some pain. But if it is, then we have to think about options. And the options first would be stop the statin for a month, let it wash out. Too often I see patients who have another statin, statin A is stopped today and statin B is started tomorrow, and their symptoms persist. And if you gave them a month washout, a lot of times the new statin will not cause the same symptom. If they do start taking another statin, then recheck them, see how they do. And if they get the same symptoms back, sometimes that'll happen. The randomized trials showed maybe 1% of patients really had statin intolerance. And that was probably because it was clear to the drug companies early on that myalgias occurred. In a lot of the early studies, they did washouts or they did screening phases where they'd give patients a statin for like 6 weeks before they randomized them. And if they failed the screen-in phase, then they just didn't put them in the study. But if patients cannot take a couple of statins, then I'm going more and more, and I think the literature is showing, just try to go to less than daily dose. And even the new guidelines in the U.S. here have encouraged considering less than daily dose. We use a lot of rosuvastatin, 5 or 10 milligrams once a week. It has a 19-hour half-life. It sticks around for a few days. And so we give them that, and then in a few months, if they tolerate it, we can add in ezetimibe, and that's a good 1-2 punch because as you increase or take a statin, you actually absorb a little more cholesterol in your gut, and so that allows the ezetimibe to work even better. So first off, believe these patients, listen to them, and tell them finally that we have medicines, we can help you, we can get you through this, just work with us for a while. And too often we just tell patients, here, take this dose. Statin intolerance is not a real issue, and they leave and just don't take the medicine and don't come back to see you, unfortunately, either.
Are there certain patients, different either demographics or ethnicities, that we should be particularly attuned to the risk of statin intolerance?
Well, there are. The Black African-American male, about 8% of this population subgroup has an elevated CK at baseline. And the reason that needs to be known is that those are patients that I frequently will check on their CK before they actually start a statin. Because if they come back to you in 2 or 3 months and they have muscle aches and you check a CK and it's elevated, you won't know if it was there to start or not. The second group is Asians. In that multi-center randomized multinational trials have shown that Asians tend to respond more robustly to LDL lowering with statins. And now the guidelines are suggesting actually starting a quarter dose on those patient subgroups. The second object to remember is that those patients also have more side effects. In fact, they have 10 times greater chance of having significant myalgias and myopathies in the Asian group compared to the Euro-Caucasian group with the same dose of statin. So just go a little lower on the dosing with those patients. As you remember, they're really important to risk stratify and to not overdose to start with.
Are there certain medications that you commonly see prescribed for other conditions that can interact with statins that we as cardiologists should be particularly attentive to?
Well, there are. We use a lot of meds in our armamentarium, and the risk of myopathy is increased when you start to give especially simvastatin with calcium channel blockers like verapamil or diltiazem. In fact, you suggested don't go over 10 milligrams of simvastatin with either of those drugs. And then with amiodarone, amlodipine, ranolazine, don't go over about 20 milligrams with those drugs. So we have to be careful. And what I've essentially done is just kind of eliminated simvastatin from my armamentarium as a new drug. Certainly if patients are on it and tolerating it, that's one thing. But I start simvastatin less and less frequently. The other drugs to pay attention to are some of the cytochrome P450 drugs, things like antifungals or immunosuppressants like cyclosporin. Be careful with those. The micromedics or whatever your electronic health record pharmacy guideline that you have access to is very helpful to look at, and just make sure that there's not a big drug interactions with statins with some of these other type drugs.
Thank you. I think that's all fantastic. And I think will certainly help in providing care to these patients when we see them in clinic. Dr. Kopecky, as we wrap up, what are some of the main takeaways that you would like our cardio nerds to have after listening to this episodes? And certainly, on a personal note, what gets you excited? What makes your heart flutter about preventative cardiology?
Oh, great questions. One of the main takeaways is that we can really help patients, and by risk stratifying them, explaining to them some of the risks that are primarily lifestyle based, and help patients. It's important, though, to talk to them, to help them realize that you're on their side, that you're going to start to drug on them, that they may have to take the rest of their life, that all over the internet says it causes muscle aches and side effects. So it really is important to treat each patient individually, as we should with all our patients. What really makes my heart go flutter? Well, it is some of the great data that we're having emerge on not only lifestyle and how that lowers cardiovascular risk. It doesn't do much to lower lipids, but it certainly lowers cardiovascular risk. And the other thing is some of these great drugs we have. We have some wonderful generics that are pills like the statins and the ezetimibe. We have some wonderful injectable drugs like the PCSK9 inhibitors and inclisiran. And the next 3 to 5 years, we'll have some even better drugs, hopefully, that lower the cardiovascular events and lower lipoprotein A levels that are associated with it. So we have a whole lot of great things coming our way to help our patients.
Well, I got to say, Dr. Kopecky, as a rising interventionalist, you're making me pretty pumped about prevention. So I really appreciate you taking the time to speak with us today. We learned a lot, and we appreciate you being here with us.
Well, it's great to be here. Thank you for having me.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Christiana Dangus. I'm an intern in the CardioNerds Academy and a senior at Boston University. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.